Bronchiectasis. Etiology. Bronchiectasis is a condition characterized by the permanent dilatation of bronchi, Figs 20 and 21, due to a variety of reasons, Table 25. No definite cause of bronchiectasis is found in over 50% of patients. Pathology. Recurrent bacterial colonization and infection lead to progressive airway injury that is mediated by neutrophils, T lymphocytes, and monocyte-driven cytokines. Released inflammatory mediators, elastase, and collagenase lead in turn to the inflammation and then destruction of the elastic and muscular components of the bronchial walls, resulting in permanent bronchial wall dilatation. Clinical presentation. Symptoms. The classic clinical manifestations of bronchiectasis are a cough and daily production of mucopurulent and tenacious sputum. Less than 10 ml per day suggests mild bronchiectasis, whereas more than 150 ml per day indicates severe bronchiectasis. Other complaints are listed in Table 26. Signs. See Table 27. Investigations. Investigations are carried out to confirm clinical suspicion of bronchiectasis, identify any potentially treatable underlying causes, and assess any functional impairment and the extent of the bronchiectasis. Table 28. Treatment. Postural drainage is the cornerstone of treatment. It should be performed at least twice daily. Antibiotics. For acute infections, treatment failure, or repeated symptomatic episodes over a short period of time following sputum sampling for culture and sensitivity. Bronchodilators, if there is evidence of airflow obstruction. Suppressive/preventive antibiotic treatment for Pseudomonas aeruginosa colonization. One representative definition of colonization requires the same organism to be isolated on at least 2 occasions separated by 3 months within 1 year. Options include nebulized antibiotics, colistin or tobramycin, and macrolide antibiotics, daily or 3 times weekly. Long-term antibiotics may also be considered in cases of colonization by other organisms, either as long-term low-dose administration of an antibiotic to which the organism is sensitive, or as cyclical antibiotics. There is of course no evidence to support the use of either. Bronchoscopy, for extraction of mucus, bronchial toilet, if physiotherapy has failed. Bronchial artery embolization, to control severe hemoptysis. Surgery. For the treatment of symptomatic localized disease, it is essential to exclude a systemic disease that may result in bronchiectasis affecting the remaining lung, e.g. immunodeficiency, or aspiration, or massive hemoptysis. Perform lung transplantation for end-stage bilateral disease. Specific treatments. Immunoglobulin replacement in hypogammaglobulinemia. Oral steroids and itraconazole in ABPA. There are no data on the efficacy of voriconazole or other imidazole agents in ABPA. Gastric acid suppression and prokinetics for recurrent aspiration associated with GORD. Recombinant human DNase, RDNase, in CF. Complications. Common, recurrent infectious episodes, recurrent pneumonias, and cor pulmonale. Uncommon, massive hemoptysis, amyloidosis, and brain abscess. Prognosis. Depends on severity. Bacterial colonization, e.g. Pseudomonas colonization, might be associated with a poorer outcome, and the underlying cause. Deterioration may be due to recurrent and worsening sepsis, or to hypoxia and cor pulmonale. Prevention. Vaccination against measles, pertussis, influenza, and TB. Prompt treatment of bronchopulmonary infections and ABPA. Early removal of foreign body and obstructing lesion. NB. If there is no obvious cause for bronchiectasis, diagnostic evaluation for an underlying cause should be performed, as the results may lead to treatment that may slow or halt progression of disease. It is essential that the patient's sputum is sent for routine bacterial as well as mycobacterial microscopy and culture prior to starting antibiotics for exacerbations, although treatment should not be deferred pending results.